So, welcome, Dr. Peacock. And I'm so happy that you took some time out of your busy day to walk us through the psychology of chronic pain and a little bit about its treatment. And if it's okay, I just want to let everybody know that they can, who are out there, they can make comments, and then we will read those comments, and if they're appropriate, and then we'll let you answer them. Okay. But I wanted to begin with one question, if you don't mind, and that is, how would you conceptualize um, uh, chronic pain from a psychological perspective? And then once we hear that, might want to then move into what we do with that in terms of developing a treatment protocol for those individuals. Okay?
Great. So briefly, my background is I'm an MD. I'm a physician, and as Steve likes to joke, I'm not the real doctor in the room because I got the MD, not the PhD.
That's right.
And I have a master's in theology, and after that, I went to medical school. So I went to Harvard Divinity, went to UVM, and then I did my medical training and residency down at Duke University, and had studied adult psychiatry. My area of expertise is also I do trauma, and I do a lot of work, and I'm the director, chief medical officer of the addictions program in Connecticut. And when Steve asked me about chronic pain, I said, I've been married for 23 years. I think I know a little bit about chronic pain.
Dr. Peacock, I have your wife Charlie's phone number, okay?
Thank you. So, Steve, so your first question was really trying to understand mostly just kind of the way to conceptualize it, or the etiology?
Yes.
Yeah.
Etiology, and conceptualize it from a psych perspective.
Yeah. It's when you think of chronic pain, and it's really tough, but we know that there are clear factors that put people at risk for developing chronic pain. And chronic pain is, by definition, pain that extends greater than the predicted amount of time, longer than usually 6 months. But there's some qualities to it that really makes it kind of chronic pain. And what is the psychology of it? And so first, when you think about chronic pain, I think about mostly, first of all, asking myself, who are the people that are really vulnerable to developing it? That's an important question. Like, not everybody that goes through an event will develop chronic pain, even if the event is essentially the same event, if that makes sense. It's some sort of insult, some sort of injury. But some people will develop chronic pain, and that's a really important question to ask yourself. If we start to think about the psychology of it, what's unique about the psychological factors that likely result in chronic pain? And so I'm kind of curious if anybody has any guesses what some of those things would be that we would be thinking, like, oh, this person would be at risk. Does anybody have any ideas? I disagree already. No, wrong. Anybody else?
Sorry, they're all in chronic pain. Anybody have some guesses? Opinions?
Would it have a good bit to do with stress and raised cortisol levels and inflammation causes and things like that?
He says, did you hear it?
I did.
He's speaking as your language, Dr. Peacock.
He does. He's going to become a psychiatrist, isn't he?
Yes.
Yeah, absolutely. Those are the things. What did he say?
He wants to be a psychiatrist.
Oh, great. I've won somebody over. Absolutely. So one of the clear factors that we know that put people at risk for chronic pain, like he had mentioned, stress, but really adverse childhood experiences. And I believe you've covered this in some. So ACEs. So what we know is adverse childhood experiences highly correlates with the development of chronic pain. And that's an interesting thing to think about. And why is that? The young gentleman just mentioned inflammation. That's an interesting factor, right? And it may be a contributing factor, but there's something about the stress response that sets people up to this. And that's interesting. So we know adverse childhood experiences is one thing. Some other factors that we know: having a family member with chronic pain. Having a family member with chronic pain increases the likelihood that you too would have chronic pain. And so naturally, people will ask me, are you talking about some sort of genetic biological vulnerability to developing chronic pain? No. And so that's not what I'm talking about. The phenomenon of chronic pain, why does it show up in the family? That's an interesting question. And because we're talking about the psychology of chronic pain, we're talking about pain being used. Now, hear me on this, and this is the tough thing for people to understand. Pain may serve a secondary function. It may serve a purpose in somebody's life when we start to think about the psychology. And I'll give you guys a clear example. What we know is young people, like young kids, if they have any sort of stomach problems before school, if the schoolyard bullying, the likelihood that they're going to develop chronic abdominal pain is high, very high. And that's really interesting. And people say, why is it that they would be likely to develop chronic pain from? Anybody have any guesses why a young kid being bullied who had just GI discomfort one day? Any ideas?
They're contemplating.
Go ahead.
Would it have to do with fear and anxiety? Or
Yeah. But it's even bigger than that, guys. And you're going to look at it and you're going to be like, oh, that makes a lot of sense. It allowed them to avoid threat. So and we know that a young kid, if you guys were a young kid and you had a GI bug and it coincided, literally just happened to coincide with also schoolyard bullying. So those two factors are in place. The third factor is that you don't have supportive family in which you're able to navigate the challenges. So you have to be able to navigate the challenges. And if I don't make sense what I'm saying, I'm going to repeat it in a better way. But it may serve a function in your life. So if a kid has abdominal pain, organic, he got food poisoning, she got food poisoning, and it kept him from having to go to school on Monday. And the schoolyard bully was there on Monday and they didn't have to go. It allowed them a psychological escape in a form of avoidance from having to be there. And now the powerful thing is it will become non-conscious outside of their awareness. So it's not like, because sometimes like I have a couple kids and kids can lie. This is shocking. Kids can lie and we call it malingering when they get a little older, but when they're little, we just say, you little liar. It's lying. But little kids can lie to, who ate the cupcake. It was probably them or me. But so sometimes kids will just make up an excuse, but sometimes the answer becomes exactly using this non-consciously because your brain will give you a solution to threat. Does that make sense, guys? Your brain gives you solutions to threat. Make sense? So chronic pain can be a solution to threat if it was introduced into your life as a solution to threat. So that's one of the psychological factors. So we know that. So I'll give you another example. So people will challenge me and say, hey, wait a minute, what about people that develop seizures in response to threat? Are you guys maybe familiar with what we call pseudo seizures or false seizures? People have seizure-like activity. It looks like a seizure. It literally looks, the medical term is called non-epileptiform seizure activity. Non-epileptiform, meaning when we measure brainwave activity, we don't see seizure activity, but they have seizure-like behavior. The predictor of who's going to develop a seizure as a form of avoidance, this pseudo seizure, is somebody who's had a seizure. Somebody who's had a seizure, and it allowed them to avoid some conflict in the environment, something that they felt like they didn't have the tools to manage, that they couldn't handle the threat, couldn't handle the stress. So chronic pain, pseudo seizures, if you frame them in the same psychological space, it will give you some understanding. So those are some of the risk factors. So it can be used, so psychologically, chronic pain can be used as a form, and we see this in young people as a way. And I'll give you a third example. We know that this is a risk factor for young people developing chronic pain, and we'll get to the adult stuff in a minute. Young kids who have had chronic illness, physical illnesses, where they've gotten not school avoidance, but a lot of valuable sense of worth and attention, especially if they didn't feel it. So young kids who have been medically in the hospital a lot, sick a lot, they will have re-experiences of sickness and illness in their life. Even in the absence, we have all the lab work. We know that they're okay medically, but they will continue to have that because it serves what we call a secondary function. So when you guys are looking at somebody who has unremitting chronic pain, and I'm throwing out other medical presentations too. Could be something like a slow seizure, could be paralysis. Chronic pain has to be framed within the understanding. Are you guys familiar with conversion disorders? So a conversion disorder, a conversion disorder is a psychological presentation that causes you to have physical manifestations of symptoms. Like, for example, you could have a conversion disorder where you have the inability to walk. We call it a psychogenic paralysis, inability to walk. But so you could have the inability to walk and nothing physically wrong with you, but the inability to walk. You could have chronic pain manifesting, or you could have something like seizures. And all of this is a psychological phenomenon. It looks just like the organic stuff, and it physically feels like it for these people. And some people, the key is, some people will say, well, these people are faking it. It's not faking. It's not malingering. It's not faking. The mind will produce the symptoms as a way to avoid threat. So people that have, like we talked about, adverse childhood experiences, chronic threat in the environment, if it gives you a solution to threat, it will be maintained. Why does it show up pain in one person, seizures in another person, or paralysis in a different person? Why does it look different? It's because they've had it as a solution. Does that make sense? Let's say I got a illness, a viral illness, and I had a seizure. We call it febrile seizures in childhood, right? If it kept me out of school, and it kept me out of school in the setting of being bullied or something bad happening, it will be maintained. It'll be maintained. So that's how it works from a psychological perspective, is that it has a function for us. Does that make sense, guys? Yeah?
They're saying yes.
Oh, okay, great. Because I'm like, does it make sense? I don't even know if it makes sense to me. No, it makes sense to me. So how do I know though, right? So how do I know that I'm, especially, okay, we're dealing with young people. How do I know that this is what we think of as non-organic, not medical? How do I know there's not something going on with it, chronic abdominal pain? We have to rule out all possible medical causes. So we have a gastroenterologist. They'll do a complete workup. We'll make sure we have imaging. We for somebody with seizures, we'll do EEG. And so once we medically clear them, we have some pretty good understanding. Now, this is the next key for something like chronic pain, or one of these things that we think of as conversion disorders. It has a curious temporal relationship, temporal meaning time relationship. It happens in time in which it serves a function. When do young kids get abdominal pain as a part of school avoidance? Sunday night. Friday night when they come home, do they have the abdominal? When they have to go to Steve Johnson's class, they have abdominal pain. But Friday night, there's no abdominal pain. So we have to be investigators. So if you're going into psychiatry, psychology, you have to be really curious investigators and ask yourself and ask those questions. Sometimes physicians, well-intended physicians, will go down the path of automatically thinking there's no psychological contribution to whether it's pain or something else. You have to ask yourself, when does it happen? Like, and does it serve a relationship to something? Now, the next thing is, we call it label indifference, which means just the French got a hold of this concept before us. But it means they have a general indifference to the illness, which is shocking. And so I want you guys, when you talk, and if you guys go into the field as a clinician, to ask yourself, because there's something strange about it when you're in the presence of somebody like this. You're like, well, geez, that would be really distressing. They're like, yeah, it is. It is. Well, it doesn't seem so distressing to them. And I've had people have significant medical presentations, whether it's seizures or something else, and I'll ask them about it, and they have this somewhat indifference to it. They're like, yeah, these things happen. It would be very upsetting to us, and it should be very upsetting. If you had paralysis, the inability to walk, and you're in a wheelchair, and you come to see me, you shouldn't be just going, it's a bummer. No, it's bigger than a bummer. It should be proportionate to the presentation. But when we have these presentations, it doesn't match. So when you see this psychological mismatch, that's another cue. And so that also tells us something. So young kids, we oftentimes see it show up in young kids, but then in adults, we see it in adults. We see this chronic pain. And like we had talked about earlier, cortisol, stress, I get that. Those are some of the factors, right? But what are some of the things that we see in chronic pain in adults? Why is it maintained? The exact same phenomenon that we see in young people, we see in the adults. We see that adults sometimes that maintain chronic pain, it serves what we call a function, a fitness function in their life. It serves a purpose. And we don't mean it like it's purposeful. We mean it allows them to not take on stress or threat. It allows them to avoid something difficult. I'll give you an example, chronic lower back pain. Many of you guys are probably familiar with chronic lower back pain. But this is really interesting. It was largely not in the medical literature. It wasn't even a diagnostic code until the 1970s. Not even like in the 1800s, early 1900s. Physicians didn't largely treat it because it wasn't a phenomenon. Chronic lower back pain became a phenomenon largely in the 70s, 80s, 90s. Now it is so common that you have a hard time if you ran a general medical clinic during the day that you're not going to see chronic lower back pain. It's a readily available diagnosis. So it is a cultural and psychological phenomenon, which is really curious. But the next question to ask yourself is, chronic lower back pain is an example of chronic pain. What do we find correlates with that? Any guesses what we find correlates with that, other than knowing Dr. Steve Johnson? Dr. Steve, oh, my back is hurting me. Okay, what's the guesses?
Charlie. Okay, go ahead.
Any guesses? Anybody?
Any hypotheses?
So
Yeah, what correlates with lower back pain? He says a shift to a sedentary lifestyle.
Yeah, you would think that, right? That's part of it, right? But that's not the strongest correlation. It's not. You would abdominal girth. Listen, I'm going to tell people what they're going to say. They're going to say imaging correlates with X-rays, CT, MRI, sedentary, abdominal girth, poor core muscle strength, all those things, right? People are going to jump to that, right? Those have relatively weak correlations with it. That's kind of surprising. You would think an X-ray would have very high correlation with chronic lower back pain. X-rays, right? Because when we do what's called radiographic imaging, we take an image of somebody's back. We can sometimes see as a part of normal aging what we call degenerative disc changes. As you get older, the disc is sometimes you'll have some shrinkage, you'll have some aging in the spine. You can look at somebody's spinal column and you can tell their relative age. You can tell a younger person versus an older person. That doesn't correlate with chronic lower back pain as well as you would think it would. It has some degree of correlation. The number one correlation is overall life satisfaction. That's shocking. So people that have a general sense of purpose and meaning and connected relationships, that get joy out of their job, that have a reason to get out of bed every day, they have less chronic lower back pain than people that report that their life satisfaction is lower. The strongest correlation is overall life satisfaction. And that shouldn't be. If chronic lower back pain was a manifestation of an underlying biological process, it should be sedentary lifestyle, poor core muscles, big bellies, bad back on imaging. In fact, some of the worst imaging we've seen when we've done an X-ray on somebody, you look at their back and you're like, oh my gosh, their back looks horrible, like significant shrinkage, arthritic changes in their back. And you would say that person should be in a lot of pain. It is not a predictor. Those people, sometimes you could ask them how they're doing. They go, I feel great. And then you have a significant portion of people, when you look at their back, you see very minor stuff going on, very minor stuff. And they will report that their back pain is disabling. What we found was it is the quality of their life that predicts, and this is shocking, and internists and surgeons are oftentimes surprised to see this information, that radiographic imaging, CAT scan, X-ray, isn't the best predictor. The best predictor is how's your life, how are your relationships, how's your job. That tells us a lot more about your back pain. which is really kind of shocking. So what does the research show, though, when we do medical interventions? If we treat it instead of the mind, we treat it. What does that show? It actually shows when we do surgery on people with chronic lower back pain and try to fix what we think could be the cause, we actually don't get great outcomes. 1/3 of the people report some improvement. 1/3 get no benefit, and 1/3 actually get worse. Well, that's really kind of surprising. About 20 years ago, Dr. Sano, he came up with a theory, and I don't think his theory, I find it a little convoluted. But I think the procedures make a lot of sense, and the mechanisms make a lot of sense. What he ended up doing, he gave permission for people to get back to their lives. He actually invited them to get back to their life, go back to work, go back to doing the things you used to do, act into the world as if you don't have chronic lower back pain. And this was the shocking research on this. 90% of these patients, and he got the worst cases, like the worst. People from around the country would fly up to New York City to see him. 90% of the people reported 100% reduction in pain. 90%, 100%. They felt better within several months. They recaptured their entire life because their pain was not tied to the actual back. It was tied to the phenomenological experience of the back. The back pain held their sense of distress in the world. Their sense of dissatisfaction in the world was held and manifested in their back. When people were able to go back to their lives, their backs got better. And that was really surprising because going to the chiropractor seems like it could be an answer for some people. Going to PT, medications. None of the patients that he had that had tried all those remedies got better, but the ones who were given permission to get back to their life. That was really interesting. So that's what the research shows, that physical pain that's chronic in nature oftentimes has a significant psychological contribution. And when we feel distress and discomfort in our lives, it will manifest itself in pain in our bodies. And the pain in our bodies, and now this is the next thing that's really interesting. When people with chronic pain wake up in the morning, they experience, and they will tell me, when I first wake up, I don't feel the pain until I remember I have pain. Well, that's weird, right? You shouldn't have to remember you have pain. And that's a very unique phenomenon, but you ask them about it, you'll say, so when you first wake up in the morning, how are you? Like, well, a little bit of a daze. I'm kind of remembering a dream. And then a few minutes later, I remember. And I'm like, there it is. And then it returns to them. So the pain becomes hyper contextualized. It's something about the environment for them. Pain becomes hyper contextualized. So for people with chronic lower pain, their experiences, I remember the pain. So when you think of chronic lower pain, we have the mistake of thinking of pain as being caused by what we think of stuff in the periphery of our body, inflammatory processes, arthritis, something injuring the body, sending information to the central nervous system, to the brain. It's not. Chronic, not lower back pain, but chronic pain in general is a re-experiencing of the past in the net presence. It's a re-experiencing of the past in the presence. And it's maintained in the presence as a way because it serves something in our life. And that's really kind of the shocking stuff about it. The data on looking at mindfulness, CBT, is pretty good, with pretty good results. Better results using things like mindfulness exercises, CBT, things like that, than with medication management, opioids, things like that, because the problem probably wasn't about the pain, but it was about the relationship to something that causes the pain. Does that make sense? I'm doing a lot of talking with no interruptions, Dr. Johnson.
You want me to interrupt you? I do have a question, Dr. Peacock.
Yes, please.
So, given that conceptualization of chronic pain, I know you want to get to the general treatment of this, right? Some ideas on that. But I have a question about if someone has chronic pain, often they may be referred to mental health practitioner, right?
Yeah.
To rule that out. Are there ways, however, in which those of us in mental health may be kind of accidentally supporting the chronic pain? You know what I mean?
I do.
Yeah.
And I'll give you an example, and it's unintended, and we do our best to take care of people. We do. Um, I had 2 patients when I was a student who were having seizures, and they were at the same time on the floor, 2 adolescents. Synchronized seizures is a phenomenon never reported in the medical literature ever. And so I had these 2 young girls having seizures on the floor, and I know there's a certain contagion to sometimes. It was pseudo seizures, it was non, but it was maintained and supported because people would run to them, and it would be taken care of, and they would give them the attention for the seizures. And so I walked in knowing what I was looking at, and I told the nurses, when the nurses said, "Oh my gosh, these 2 young girls are having a seizure," I said, "This is not an Olympic sport, doing some sort of synchronized seizures." I don't think they found me particularly funny. I said, "It's not seizures. They don't need Ativan, and what they need to do is not to be reinforced." And it sounded cruel, and what I meant was, don't run to them. And I told the nurses, don't run to them. I literally said that. And they looked at me like, "What are you talking about?" I said, "They'll grow tired and they'll go back to their rooms when they're ready." And so when I walked by them, I actually told the 2 young girls, I said, "Hey, when you're ready, you can go back to your room." They looked shocked because I was supposed to run to them and go, "They're seizing," and stop them from seizing. How did they know they were not seizing? Well, first of all, it was synchronized. The second thing was they weren't doing anything that would harm themselves. They weren't, when you're having a non-epileptiform seizure, you're not going to injure yourself. You're not going to bang your head against the ground. Real seizure activity, you'll bite your tongue, you'll be incontinent, you'll have none of the telltale signs that this was organic was happening. So with chronic pain, they will do all the activities that look like they're in pain. And they are in pain. I don't want people to hear the message they're not in pain. It's real when you ask them about it. But what Dr. Johnson, what you're asking about is, how do we maintain it? It's unintended. When I was a student, I was trained to give tissues to people when they were sad, and I was to maintain that idea, like, here's your tissues, and I would give them their tissues, and I would recognize their sadness, and I would maintain their sadness and depression. I would also maintain their anxiety, because I would ask them to only focus on anxiety. And unintended, I would say, "How is your anxiety this week?" And I would put it on a scale. I would say 0, you're superhuman, you never have anxiety, you're a sociopath. Like, what is this human that has no anxiety? To a 10, which is a full-blown panic attack. And they would have to track their anxiety for the week. And then people with depression, they would have to track their depression for the week. In fact, we were just getting used to using what we called mood trackers back then, and some of you may be familiar with it. It was an app. Now it's an app, but we would actually have them map their depression for me. If we were so embedded in maintaining it. And the problem with psychological phenomenon is that the human brain is designed to detect patterns. When I ask you to detect the patterns, you'll find the patterns and reinforce the patterns as a phenomenological experience. So people with anxiety, when I ask you to report your anxiety, you get really, really good at noticing when the world is scary. When I ask you to report how depressed you are, you get very good at reporting how depressive life is. But the problem with that is that the human brain is designed to detect patterns. And so we develop what we call an inability to be able to see. We actually cancel out opposite experiences in our environment. So if I asked you to just get really good at naming blue objects in a room, you get very good at blue objects. But if I said what was green in the room, what was red in the room, you stop seeing those. You get a blindness to that. The medical system, including psychologists, as well-intended as we are, and not thinking about how these things are maintained, we maintain them. And we maintain the chronic pain because we send them to the chiropractor, we send them to the therapist, and we ask them, how is your pain this week? How is your pain? How is your anxiety? How is your depression? Now, this is startling information for people to think about, because when you think about medical conditions, with something like even an infection, you're going to monitor signs and symptoms of an infection, fever, things like that. But this is different when you have psychological manifestations. When you focus on it, you embody it, you maintain it. And with chronic pain, it is maintained by the very act of sending them to the pain specialist and having us talk about it. So then people will ask me, what is the opposite of focusing on that? What is the opposite of anxiety? Well, what were the things that made you feel really great this week, excited this week? When we start to do that, we get rapid changes in people, rapid changes in their experiences when we no longer focus on that. And people are like, oh, are you saying that we shouldn't be asking them about it? What I'm saying is, when you focus on that, which is inconsistent with the experience of anxiety, excitement, and engagement, they start to experience the world as exciting and engaging, fun. And when people start to engage in life and you start to ask them about some of the things that brought them joy for the week, and they get really excited about it, their experience of pain becomes less. And that's really interesting. And so with conversion disorders, when I don't focus on those things, but we focus on getting them to solve their challenges, conversion disorders show up when people do not feel like they have the tools and the skills to handle the challenges of their life. When they feel like they don't. But when we focus on setting goals and solving problems, they don't need to use tools, non-consciously, tools of avoidance. They don't need to use those. Does that make sense?
Larry, someone might say then that you are against sending them to pain specialists for pain management. Do you have some kind of flow chart in your head to help you negotiate when it's warranted to send them to pain specialists and when to begin to look at those more psychological phenomena?
It's tough, right? So for anybody who's recently experienced any sort of acute painful event, what we do know is managing pain improves health outcomes. It was taught to us in medical school to treat it much like a vital sign. What is their pain? What is their blood pressure? And we should be managing because we have all the tools to be able to manage acute pain, and we should manage that because people shouldn't suffer unnecessarily. However, the knowing when and how to manage these people when it starts to, because not everybody will convert into chronic pain, and not everybody's experience of chronic pain is the same, and not everybody's experience of acute pain is the same. But there does come a point where we start to notice that they no longer are able to participate in the activities of daily living, and that it has gone beyond the expectations of the normal course of what we would anticipate. And we have to approach this with the possibility that we're wrong and a real curiosity and non-judgment, because it still is a presentation. When I have somebody having pseudo seizures, I treat it with a real sensitivity of knowing that they're having an event that is very much real, and it is real. It just doesn't, it's not treated the same way. So pseudo seizures do not respond to anti-epileptics, Keppra, Depakote. If they do, it's temporarily. So then I try to figure out what is going on in their lives that we can do to help them solve their problems. So if we have a hypothesis, and people will tell you, they'll tell you what the problems are in their life if you just ask them. They'll tell you about their marriage, they'll tell you about their job, and sometimes they'll tell you about their marriage and job because they haven't told you about their marriage and job. And then you'll ask them, I've heard a lot about what's going on, but I haven't heard nothing about your wife, and you've been married 25, 30 years. How's your marriage? She moved out about a month ago. We haven't been doing well. Oh, can you talk about that a little bit? So what I do is I find the information. If you're going to be doing therapy, you have to pay attention to what's said and what's not said, what's said and what's not said. And when we start to focus on the things that matter in people's lives, because people will use this as a way of not talking about things. And trust me, if you're doing individual psychotherapy with somebody, their pain in their back gets worse when they start to get uncomfortable, when they start to talk about the things that really bother them. They're like, do you mind if I stand for a moment? My back is hurting. They're like, I don't mind at all if you stand for a moment. And then you continue to explore this. But doing the work of helping them solve their problems of living makes them better. And sometimes unprocessed grief will show up in physical ailments. It literally will show up in their bodies. And I've seen, and sometimes as you start to process and talk about the things that make them uncomfortable, you'll see a worsening of these symptoms. And I'll give you an example. When you're dealing with a child who wants to be able to avoid something, you'll get worse symptoms, you'll get tantrums. And parents will come to me, they'll say, are you telling me I should ignore the tantrum? The tantrums will get worse before they get better, but they have to make that developmental leap of solving problems. Tantrums get worse. Back pain gets worse. Chronic pain will get worse until they develop the tools. But once people break through that and start to develop the tools to take on the challenges of their life, working on their marriage, working on their job, taking on the personal responsibility of their life, they start to have a significant reduction in symptoms.
Dr. Peacock, we have a little bit less than 15 minutes.
Oh.
So I have one question that has kind of two parts, but not really two parts. And that is, a good number of the students in here are thinking that they might go get their master's in, to be a master's level therapist, LPCs, MFTs, that kind of thing. Are there ways for them to partner with physicians to help with these chronic pain that have psychogenic, origins?
Yes.
And what kinds of treatments are you finding helpful with that type of chronic pain?
Yeah. There are ways. In fact, chronic pain clinics are, including like oncology clinics, which deal with organic, real significant pain associated with cancer, are oftentimes, and mostly you'll find this in the large medical centers like Dana-Farber, have psychologists on staff, have therapists on staff that are really helping people, because some of the most effective strategies for managing pain isn't what people think it is. And that's really interesting. So it's medications. I mean, the data is pretty mixed on medications. There's a robust, fairly interesting placebo response to medications, depending on the quality of the relationship. But you know what they find is connected communities, support, decreases people's experience of pain in the world. And that's really interesting. When people feel connected, when they have relationships, they do better. And we know that. And so we know that it's the quality of relationships. So as a therapist, as a psychologist, as a psychiatrist, the quality of your relationship, the very relationship itself makes their experience of suffering less and their pain less. And then they start to actually feel like they can take on the challenges of their life. There was an interesting study, and Steve, Dr. Johnson, you and I have talked about this study a lot in a context of addiction, but it has the same application here. Professor Profit, it doesn't sound like a real name, Profit. He did an interesting study where he had people looking at a mountain, literally just looking at a mountain. And he asked them to measure the slope of the mountain, like how steep is that mountain? What he found was when people stood by themselves looking at the mountain was much steeper than if they had somebody looking at it with them. So he had people looking at a mountain. So the experience of pain is enhanced when we see the environment is more threatening, because again, like we talked about, pain, not acute pain, chronic pain can be a phenomenon of avoidance, pseudo seizures, addiction, using substances, avoidance, being on TikTok for 5 hours when you have to deal with some challenges of your life.
Or an exam in health psychology, yes.
Eating cupcakes at 2 a.m. So chronic pain, cupcakes. I mean, we have behaviors of avoidance, and chronic pain offers a solution. But the solution is when people feel like they feel connected towards a distant goal, the mountain actually literally got smaller. He found that to get smaller. The study found if we gave sugar to people, it made the mountain small for temporarily. So the cupcake at 2 a.m. makes the world feel less scary. And people will often ask us, so are you saying that when I look at a mountain, it changes? I don't look at mountains all day. No, but when you look at the exam that you have to take for a class coming up, and if you feel alone and lonely and anxious, the exam feels more threatening. The email feels more threatening. The phone call from your mother feels a little harsher when you don't feel connected. But when people feel like they're connected, everything is experienced differently. We live in a virtual rendered world around us. Chronic pain doesn't have to be a solution for the mountains that feel steep when we feel connected. And the relationships make the mountains. he did multiple studies in his lab. They did other studies where they would have you look at a finish line. Finish line got closer when you felt you're in a connected relationship. The number of stairs you have to climb looked like less stairs. When they gave you a backpack with weight on you, when you were by yourself, the backpack felt heavier than when you were with somebody else. So there is something about connected relationship. And this is a really interesting thing about chronic pain. People that have a deep sense of faith or purpose, meaning, or a God, a belief in God, actually experience pain in a different way, and they have a less phenomenological experience of pain, because the belief in God has a way of modulating pain. That's really strange for people to think about. They're like, really? The belief that there is somebody with me, a personal God for people, actually makes the experience of anxiety, depression, and pain less for people, physically less. Like they actually rate it as less. And that's a really interesting phenomenon. So, yeah.
There's a question there. What is,
Okay, yeah.
But what if you just told me, hey, you're like, actually, it's just like a chronic thing, and it's not like actually something wrong with you. Like, what would
could you hear that, Dr. Peacock?
What was that? I couldn't hear it.
She was saying, what if you just told them that what you're experiencing is not actually pain? Would that be of help?
You got to be able to deliver that information in a way that's validating and sensitive.
Yeah.
Because it could be misheard. And so the way I deliver that information is, I understand that you're experiencing pain, and I understand that it can be quite distressing. And then I explain to them, sometimes the mind has a way of making things more uncomfortable for us when we feel anxious. And they go, oh, so you're saying that part of my experience of my pain is because of my mind? I go, yes. And then they ask me, what are some of the things that would help me? And then, so what I do is I turn it around on them. What are some of the things you've noticed in your life that made you feel better? The people have solutions. They have solutions. And they'll say, when my sister was living with me, I felt a little better. When I was actually going bowling on the weekends, I felt better. When I would work in the garden, when I had a really good prayer life, I felt better. They actually offer up the solutions. So I introduce it in a very non-judgmental. And so unfortunately, we have therapists, psychiatrists, internists that will introduce the information in a very hard way, where they'll say, it's just stress. It's just your mind. It's not just stress and just in your mind when you have a hard time getting out of bed in the morning because you hurt so much. When you hurt that much, the body holds pain in a way that's interesting and phenomenologically it's a real experience for people. Now, this is something that most people don't know. And even therapists and, Dr. Johnson and I teach people this all the time. And this is something to be really important for you guys to get. Sometimes the experience of pain is in one setting, but that same discomfort, it's called something else in a different setting because it becomes a different solution. So when they see the pain specialist, they report their pain. But what they're really reporting is, I feel uncomfortable and I feel threat in the environment. Something is making my world feel unsafe. But when they go to the addiction doctor, they actually say, I'm actually having a lot of cravings recently. Pain in one setting, cravings in a different setting. But what they're both saying is the same thing. Now, this is really gets really interesting. Pain in one setting, cravings in another setting. And then when they're at school or back at the college, if they found themselves that they used to binge drink, they'll say pain, cravings, they'll say, I have an urge for binge drinking. In another setting, when they used to be home by them.
Not at CIU, not at CIU. Okay. It would be binge cupcaking, okay?
Yeah. Cupcakes. But when they're back home, they might say, I had an urge, I have these urges or these impulses to cut myself. I cut myself. And then let's say they have an eating disorder. But everything has a context in which it's a solution for avoidance. Chronic pain is the solution in one setting. Cravings is the solution. The urge to cut is the solution. But what it is really, it is the mountains, the threat, the anxiety, and the solution always is finding a way to solve your problems in ways that are connected to community, relationships, something deeper, and a belief in even something else, a belief in the future self, always reduces pain, always reduces cravings. And so all of these are phenomenologically the same thing, just in a different context, if that makes sense. And so we ask mistakenly as if they're different things, but they're not.
Yeah, I like that. I want to go back to the very beginning when you were talking about this, is that you did talk about validating it, but validating it in a different way than we often do. You were
Yes.
saying validating that they are having they're experiencing pain and they're in great discomfort, but not validate their interpretation of the origin of that pain.
Correct. That's
Right.
exactly it. We don't need to, and that's the mistake we've made in medicine. When we have chronic pain is largely a psychological phenomenon. But when we make the etiology built on injury to tissue, and we know that chronic pain shows no evidence of tissue injury, and largely, don't get me wrong, there are rheumatological disorders, rheumatology, so we have certain arthritic stuff that shows changes, right? But in general, chronic pain has a psychological phenomenon that doesn't show evidence of. And once we can document, there is no evidence of. But this is really even more fascinating. Somebody had mentioned earlier inflammation. When people experience the world as a place of threat, and my son had asked me about this earlier today. People, we make the interesting unidirectional. We think biology creates psychology, but we don't actually appreciate psychology can and does create the biology. Somebody had mentioned earlier today inflammation. And what we know is when you experience the environment as threatening, you actually have an increased inflammatory response. So inflammation can cause pain, but the experience of threat can cause inflammation. And so people will ask me, why is that? Why is that? And so this is interesting. The reason why when we feel threat, we get increased inflammation is because we used to live in mostly tribal communities, not the 21st century of going to Sonic and McDonald's, but communities in which we could be. I know, who doesn't like Sonic? There's no Sonic in Maine, but in communities in which if we were under threat, having inflammation may have kept us alive if we were bitten by an animal. So inflammation, if you got bit by an animal, you would get an abscess, and it would prevent you from getting what's called sepsis. Sepsis is where you get infection throughout the entire body and it can kill you. So people that chronically feel threat have increased inflammatory responses. People that feel chronic threat, risk for chronic pain, if they get a viral illness like COVID, they get a lot of inflammation, and they get very sick because of the psychology impacts the biology. Psychology impacts biology. That's really powerful.
Dr. Peacock, and on that note, we need to end. I want to thank you so much, and everybody out here is thanking you. They're smiling and shaking their head yes.
Wonderful.
And thanks so much for taking so much time from your busy schedule to help us get a better understanding of chronic pain. Look forward to inviting you back in the class another time. Okay?
All right. Thank you. Take care. Bye.
Have a great day. Bye-bye.